I explain the procedure to the patient to obtain consent and reassure them. I make sure the patient is sitting upright, preferably with their legs over the edge of a bed or chair, and ask them to remove their shirt. I ask the patient to point to their lower ribs to assist in locating the bases of their lungs. I ask the patient to breathe, taking slightly larger breaths than normal, and slowly through an open mouth to minimize added noises. I press the diaphragm firmly enough upon their back to leave a blanched ring on the skin after removal. I keep the stethoscope still and the tube clear of contact with objects during auscultation. This decreases extraneous sounds. I listen to both sides of the chest in a systematic way, from the bases to apices, and directly comparing the right side with the left side over 2 or more full respiratory cycles at each point. Sometimes I ask the patient to move their elbows together, which creates an increased area on the back between the scapula. While listening, I note the quality and intensity of the lung sounds during inspiration and expiration, while considering and listening for the following: quality of air entry. Are the lung sounds normal, vesicular? Are the lung sounds equal on both sides? Is there a wheeze evident during expiration, inspiration, or both? Are there coarse or fine crackles evident during expiration, inspiration, or both? I now assist the patient to get dressed if appropriate.